Dr. Partha Vishwas, Dr. Harshul Talk, and friends. I will be speaking on surgical pulse for managing complex pediatric cataract cases. If you see these children, they come to us with visually significant cataract. And you will see majority of them, they are bilateral, and 10 to 15% of them are unilateral. Each of the eye which we operate, you have to dilate to see the morphology of the cataract and plan the type of the cataract surgery which you are going to do. Only then you can detect these complex cases. So this is one patient, posterior lenticonus. You cannot find it out if you do not dilate the pupil. After dilatation, we know that there is a lenticonus, and that is a posterior lenticonus. We stain the anterior capsule with trypan blue dye and perform continuous curvilinear capsular axis. Size of the axis is kept around 5 mm. A limited hydrodissection, because if you do vigorous hydrodissection, it lead to rupture of the posterior capsule. Cortex is removed, and you can see that this is the posterior lenticonus, and which we will deal after implantation of IOL, that is hydrophobic acrylic IOL, in the capsular bag. After implanting IOL in the bag, appropriate size posterior capsulotomy was done, and this has ensured the implantation of IOL in the bag. And this triamcinolone, this helps to detect any of the traction which is there, vitreous traction. In smaller children, we place suture particularly on the main incision. And then coming to some of the other complex cases, that is subluxated lens with high corneal astigmatism, 4-year-old girl. Here there are few challenges. One is that it is a subluxated cataract. Most important here is to achieve the perfect centration of the IOL after performing the surgery, and another issue is how we manage the cylindrical error or the toric, because this toric IOL astigmatism, there is a significant astigmatism. So here we have applied hooks to the rhexis margin and removed the cortex, and then fix the capsular bag with the Sioni ring. Almost perfect centration of the capsular bag is achieved. Then implantation of the toric IOL into capsular bag, and this is Callisto where we have used in this case. And then comes another complicated case, that is PHPV, or now known as persistent fetal vasculature in children. It produces lot of complication, particularly vitreous hemorrhage, if no cauterization is done. So this is some previous case which we have documented. So these are the animation, how we should do it, how we cauterize the vascularized membrane, and then how we cauterize the stalk. These are the animations, and then come a real case, 2-year-old child with persistent fetal vasculature, and there is a thick vascularized membrane, very thin anterior capsule, but we could achieve a perfect rhexis. Cauterization of the membrane, vascularized membrane, and it is difficult to cut it with the retractor. So we used vena scissor and then cauterized the stalk, and then implantation of the IOL in the capsular bag. These are some of the other situations in PHPV which we have managed. So this cataract associated with PHPV is a challenging situation, and we can manage it. This is again a very challenging situation, that is double crystalline lens in a child where cornea was very big and there was partition in the center, and on complete examination showed 2 crystalline lenses. We thought that what should be done in such a child. Though this is extremely rare situation, customized IOL was made for this child. 3 of the IOL were there because we thought that we may not succeed, or if there is breakage. So we did 2 continuous curvilinear capsulorhexis on each of the lobe of on these 2 crystalline lenses in the same eye, removed the cortex from the capsular bag, and implanted this mega IOL into capsular bag on each side. Single IOL in these 2 crystalline lenses, central area was aphakic. We found a gradual increase in the size of the visual axis. We anticipated contraction of the posterior capsule, so there was gradual increase. So we could manage these double crystalline lens. So I am not going to show much because my time is close to over. Long-term follow-up is important in these children with pediatric cataract. This is one child operated in 1997, and 25 years later he has completed his MBBS now only recently last year, because he had excellent vision. Thank you very much.